the shock absorbers of the body. So when you jump and you land and you stiff leg the ground, that shock is going through these bodies. The disc size is going to vary from the top on down. So there's going to be some differences. The next component is, if you look at this annulus fibrosus cross-section here, the direction of these fibers, they're not perpendicular to the vertical force. So they're not horizontal, they're actually angled. And they're angled in alternating concentric rings. So each ring has fibers going in the opposite direction. What is that going to do for us?
More support, more shock absorption.
What kind of support? Not so much shock. Multiple directions. So this is kind of like, if you compare this to the cortical bone and the trabeculae, which is which? Which is cortical? What's cortical bone?
You mean like spongy?
Spongy versus cortical is, trabeculae is spongy, cortical bone is the harder outside.
Like Wolf's lines, like the
Cortical
So
is the outside of the bone.
is the one that handles
Right.
compressive forces. The nucleus pulposus, the squishy stuff on the inside, is kind of like the cortical bone on the outside. So the discs are somewhat inverted from how the bone structure is. So your shock absorption is handled from the nucleus pulposus. It's like taking a gel pack,
It's just the outside of the bone.
putting Magellan inserts in your heels, in your shoes. You put that gel pack in to absorb that impact. The annulus fibrosus is more like the trabecular bone, in which you've got alternating rings that handle the shear force and handle the multidirectional instability. So the annulus fibrosus, the outside of the discs, is really kind of functioning like the inside of the bone. But the inside of the disc is handling compressive forces much like the outside of the bone would. I don't know. Disc details. So no disc between skull and C1 or C1 and C2. So there's your exception to the rule. The ratio of disc height to vertebral body height is greatest in the cervical region. So as that lumbar body gets bigger and bigger, the disc has less impact on it. The discs are comparatively thicker in the cervical spine. They're composed of water, collagen, and proteoglycans. So it is true that if you go to sleep and wake up in the mornings, then you're a little bit taller in the morning. Because as the mass of your body is upright and gravity is pushing down on it, it pushes a little bit of fluid out of those discs, which means your body's about a quarter inch shorter at the end of the day than you are at the beginning of the day. So women, if you're a little conscientious about your height, or guys who are like 6 foot or 5'11" and a half, always measure yourself in the morning. To get that little bit of bump up.
6 foot when I wake up.
My short little sister, 5'1" and a half, always swears up and down she's 5'2". I'm like, lies. Of course, I have another friend who she swears that she's 5'12". So the higher the ratio of proteoglycans to collagen, the increased resistance to compression. So the proteoglycans really are kind of the filling that kind of helps absorb some of that force, whereas the collagen is kind of creating that resistance to shear forces. And then there's a difference in the type of collagen. Type 1 and type 2 predominate. And then type 1 is found predominantly in tissues resistant to tensile forces. Type 2 found in tissues resistant to compressive forces. How are we on time? We're doing okay. So collagen arranged in concentric circles, sheets called lamella. And they're oriented at 120 degrees to one another. So like I said, those fiber orientations alternate as you get in through concentric rings. The ratio of type 1 to type 2 is greatest in the outer rings. And the ratio, and then it alternates as you get back in towards the nucleus pulposus. Or in the concentric rings closer in. In abnormal state, the ratio is altered in an undesirable way. So type 1 gives us resistance to tensile forces, which is going to give us our shear force restriction. And so on the outside edges of our annulus fibrosus, those outer concentric circles, we have a greater number of type 1 fibers, which gives us that more resistance to the shear force. And as we get in towards the inner rings, in towards the nucleus pulposus, we have more of these type 2 collagen fibers, which are necessary for compressive forces. However, in an injured state, over time and inflammation, that's going to switch those things around to where our compressive force resistance isn't as strong on the inside, and our resistance to shear force that should be on the outside isn't there. So things start falling apart. So there's a slide of it, and there's a pretty picture. So nucleus pulposus, what is it? 60 to 70% is water. It's deformable but not compressible. So you can squish it, but it's not going to change shapes. It's going to absorb some of it and move a little bit. And then it's semi-gelatinous, which means that it is in fact kind of a mush of sorts. So what exactly is a disc herniation? Again, that'll come in ortho, but if we start rupturing the annulus fibrosus, the outside layers, if we start allowing that nucleus pulposus to compress, to move, to jelly out, if we break those rings, it's going to start squishing out. And so you'll get something like this poor guy over here has, which he's got a happy little bulge down here from a disc squishing out. And they painted it red. And I'm sure it's painted the exact same way when you cut it open. There's the red spot, like it's an X on it. Cut this out. I'm sure that's the way surgery works, right? Somebody forgot to color code the new knee ligament for them to find it in time. Our articulation, 6 different motions. We can flex and extend, we can rotate, and then we can tilt for lateral bending. And then there's translatory or secondary motions. There's a forward glide, lateral glide, compression, and distraction. So the major motions we have are certainly going to be impacted by the secondary motions. And the secondary motions are a lot of what we can use with therapy to help increase mobility within the spine. Because if we're going to get restrictions or arthritis or decompositions, it's going to hit us in some of those more subtle motions as they begin to break down. So extension. If we extend, we're going to put a posterior pressure on the disc, which means it's going to open up in the front. If we flex, it's going to give us the opposite. And then lateral bending, to where if we put pressure on one side, then it's going to open it up on the other. So if we start having disc problems and we start having somebody complaining of an injury to where there's radiating pain where a nerve root is impinged in the spine, if the impingement is at the level of the spine, then what we're going to see is that if it's usually going to be down one side or the other, that you can find a way to move them that both makes it worse and makes it better. So typically if it's a tilting problem that's shooting down my right leg, if I move left and that makes it worse, if I move right, it's going to make it better. Simply for this matter, if I move left, it would be pinching on it, and if I move right, it's going to open up that other side. So you can kind of identify where through eval, and you'll get into that as you go, but you can start trying to identify not only where that disc bulge is as far as which side it's on, but how to treat it as well. There's a whole spinal approach called the McKenzie method, which deals with identifying which muscles you have or which motions are the problems, and then you can kind of reinforce and allow that healing. Allow them to have some healing. So coupling, consistent association of one motion about an axis with another motion around a different axis. This concept is kind of like we had coupling within the scapula. So we have serratus anterior pulling on the medial border of the scapula, pulling it outward, and we have the rhomboids attaching on the medial side, pulling the opposite direction, to where it's kind of controlling where that scapula tracks. We get the same idea in here. But by region of the spine, that concept changes. So mid-cervical, lower cervical, upper thoracic, rotation to the left, and forward flexion are all coupled together.